Good afternoon. My name is Preethi Pirlamarla. I'm an advanced heart failure and transplant cardiologist at the University of Washington. And thank you to Dr. Longnecker and Lindsay for inviting me to give this talk.
Preethi, you have a connection to North Idaho as well. You want to talk about that just
Yes,
briefly?
yes, and I do go to Coeur d'Alene. We do have a clinic there that myself and three of my colleagues we go. We average once or twice a month to come to deliver advanced heart failure care there.
Great. Well, thank you. Okay, well, let's get into it.
Great, thank you so much. Today I'll be talking about advanced heart failure therapies. So kind of focusing on the end of the spectrum of heart failure. And I'll try to keep this as brief as possible. I was a little ambitious with the slides, but I'll see how much I can cover. And I want to focus mostly on the advanced heart failure features. So kind of the learning objectives today is identifying features that we associate with the advanced heart failure phenotype, the options that we have available for these patients, and we call these the advanced therapies, that mainly being cardiac transplant and left ventricular assist devices, or LVADs. So going over briefly what the indications and the contraindications are, becoming familiar with the basic components of an LVAD and its general mechanism of action, and also understanding the basics of both cardiac transplantation and LVAD therapy. So I wanted to just start off very quickly with just looking at heart failure by numbers, because it really is astounding when we see how affected people are with heart failure. There's an estimated 6.7 million Americans over the age of 20 that carry a diagnosis of heart failure, and that is projected to increase algorithmically in the next couple of decades. By 2020, we're projected to see about 11.4 million Americans carrying a diagnosis of heart failure. And it was estimated in 2020 that it was responsible for $32 billion in direct costs and an additional $14 billion in indirect costs. And we know that the lifetime risk of heart failure increases to 24%, meaning on average, 1 in 4 Americans will develop heart failure in their lifetime, which is really a very sobering statistic. And these numbers are really astounding. And we see just how much heart failure is an epidemic, which really behooves us to find aggressive therapy, early detection, and close management of these patients. And why do we care about heart failure? We know that because heart failure is overall a downward trajectory since diagnosis. And I'm sure we've all seen these patients where they come in, they have an acute heart failure exacerbation, and they end up hospitalized. They get diarrhea, started on medical therapy. But what we really find is that they never truly get back to their original exercise capacity or their activities of daily living. And we know that it's a general decline in these patients. And we see this despite guideline-directed medical therapy, mechanisms of different devices, et cetera. And we also know that as they progress through heart failure, the mortality increases. So someone who's stage A, meaning that they have no structural changes and risk factors only, might have a 2 to 3% 1 year mortality. But then when we get all the way to stage D, that mortality increases to over 50%. And this mortality rate is irrespective of ejection fraction. So when we talk about heart failure, just to kind of go through the stages, we know there's stage A, B, C, or D, where stage A is at risk for heart failure, but they don't have structural disease or symptoms of heart failure. B is where they have structural heart disease, but they may not be exhibiting signs or symptoms yet. C, which is kind of the mainstay of patients that we generally see, which is where they have structural disease, whether that's coronary disease, et cetera, with prior or current heart failure. And then we have all the way to D, which is refractory or end stage or advanced heart failure. And these are the patients that have heart failure symptoms at rest, hospitalizations despite being on medical therapy. And these are the patients that I'll be focusing on today. And these are the patients that have the highest mortality. So when we talk about the advanced heart failure phenotype, what do we mean exactly? And so when we look at these patients, we really use specific types of landmarks in order to define that phenotype. We look at their functional class, their intermax class, their exercise capacity, which is something that's actually measured, so it's an objective data point, and that's using a cardiopulmonary exercise stress test, where we measure different parameters such as a peak oxygen consumption, and then clinical events or landmarks that you might see in this patient during their course, that would be flags or red flags, I should say, or landmarks that they might be sliding into this advanced heart failure. So as we know, there's NYHA class 1, 2, 3, 4, which is where you have cardiac disease but no symptoms, class 1. So these are patients that are very functional. They actually have minimal to no symptoms. Class 2, which is where they have mild symptoms and some limitations during ordinary activity. Class 3, which is where they have marked limitation, and that's at minimal activity. And then you have class 4, which is where they're even at rest. They have symptoms. And these coincide with something that's called the Intermax Registry, which is a registry that is used by clinicians to categorize clinical characteristics of these patients. And it was named initially for LVAD patients, but we've since extrapolated them for the clinical course of all heart failure patients. And that can coincide really with class 3 and class 4 symptoms. And I won't go through all of them, but class or Intermax 7 is where they have advanced NYHA class 3 symptoms, all the way down to Intermax 1, when these are the patients that are critically ill, cardiogenic shock, on ECMO, on balloon pump, et cetera, that are in the hospital. And the reason this is so important for classification is because it helps define what these patients are clinically, and it helps us identify where they are on the spectrum and how aggressive we need to be with certain therapies, whether it's medical therapy, advanced heart failure, options, devices, et cetera. So it really helps classify and define these patients. So we were talking about functional class, intermax class, and then we have clinical events. And that is defined as things that might happen throughout their course or their medical history. And these are also red flags that you would look for in your clinical practice. Things that you might see is this a patient that's being repeatedly hospitalized for heart failure? Is there a rise in their creatinine? Are they having a decrease in their renal function? Also not listed here, but are they having worsening hepatic function that really doesn't coincide with anything that they might be taking or other clinical events? Are they having weight loss without other causes? And this we define as cardiac cachexia and is a sign of an advanced form of heart failure. Another very important flag is, are they no longer able to tolerate their medications? They might have been on a high dose of Entresto or sacubitril valsartan or high dose of carvedilol, and all of a sudden they're hypotensive, dizzy, lightheaded, their blood pressure is dropping into the 80s, and you're finding that you're scaling back on these meds. This is a hallmark of advanced heart failure patients that really should signal that these patients are declining rather rapidly, and they're showing that they are now in more advanced symptoms. They might have an inability to walk one block, or they can't really do anything because they're dyspneic at rest. Do they have a progressive decline in serum sodium? And this is one of those very large hallmarks of a poor prognosis in heart failure. Persistent hyponatremia because they have persistent hypervolemic hyponatremia. So these are all clinical events that should signal that this patient is approaching end stage or advanced heart failure. Other additional considerations that would signal advanced heart failure is, are they requiring inotropes such as milrinone or dobutamine? And another classic one that we might see in these patients is, are they suddenly not responding to their CRT device, which is a cardiac resynchronization device? There's about 5% of patients who generally don't, but if you have a patient who may not be responding, but they used to, that is another sign that these patients might be declining and having more advanced features. The last thing that we look at is objective testing for these patients. So this would be a cardiopulmonary exercise stress test. And these are something that you might have seen out in when we talk about athletes and they're doing their assessment of their functional status or their fitness. So you might see this on these patients where they have this giant mass and they're on a treadmill or they're on a bike. So this is actually an excellent test that we use in our advanced heart failure patients to see if these patients may have signs of advanced heart failure. So when we look at these, what we are looking at is what their effort is. So that helps us look at this rate of oxygen, their expiratory effort and their carbon dioxide exhalation. It also looks at what their symptoms are and how they're feeling and what their maximal effort is. And that's something that we look at, which is the VO2 max, which is the top number in this equation, which is how much how much oxygen is the heart consuming at maximal effort. And this is all plotted on a graph, and it helps us see where they are from an objective functional standpoint. So I think we go to the next, yes. So when we look at these patients, this really helps define and prognosticate these patients, because what we look at is what is that peak VO2, meaning what is their oxygen consumption at maximal effort. And this actually was defined decades ago, and the hallmark paper was in 1991 by Dr. Mancini, who was really the forethought leader in this. And what they found is that when you look at a peak oxygen consumption of these patients, and the number that we use is 12 if they're on a beta blocker, or 14. And if their peak oxygen consumption is over 14, it predicts clinical stability over the course of 1 year. But if it's less than 14, that's when we start wondering if this patient needs advanced therapies, and when we start to look at whether or not we need to be thinking about other therapies for this patient. And really, this has become a cornerstone in how we manage these patients. So next slide, thank you. So we have a patient now that we have identified might have advanced heart failure. So, and you've looked at them and you've defined them because they either have a functional status or they have a clinical deterioration, or their peak VO2 and their CPAT is getting worse. So what do you look at that point? So it's either an LVAD, which is a left ventricular assist device, or cardiac transplantation. So switching gears a little bit, I won't spend too many, if you can go to the next slide. Thank you. So I won't spend too much time on this, just in the interest of time, but I just wanted to go over what an LVAD is. So an LVAD, which is a left ventricular assist device, essentially is a surgically implanted durable mechanical support device, which is designed exclusively to unload the LV through what's called an inflow cannula, which is then put through a pump, and then it circulates blood to the aorta, and it leads to end organ perfusion. So it essentially takes over the function of the LV. And I just want to make a note, if you notice, it's exclusively LV support. It does not provide RV support, and that becomes kind of more important later on in the slides. So an LVAD can be implanted as two strategies, either as a destination therapy, meaning that is the final therapy for these patients because there may be some reason that they have that would preclude them from cardiac transplant, or as a bridge to transplant, meaning this is not the final stop. They may have some other barrier that they may need to overcome or work through, and this is placed as a device in order to stabilize them and then wait for them to be able to get to the point that they are eligible for a transplant. So it can be a DT, or a destination therapy, or a bridge to transplant. Next slide. So just to go over very briefly what the components of an LVAD are, there's a few basic components. There's a pump, which is sewn into the LV, an inflow cannula, which is where the blood is routed to. This then goes through an outflow graft that is sewn onto the aorta. It's connected to a pump that powers it. It has a percutaneous lead that goes from the pump to the controller, which is called a drive line, and that's number 4. And this is connected to batteries that run. So if you go back one slide, keep going forward, sorry. Yeah, one more, perfect, thank you. So this is the basic components of what was called the HeartMate 2. It's an older device. It was an axial flow pump, and this is just kind of a closer look at how the blood goes from the inflow cannula through the pump, and then it gets ejected to the aorta through the outflow cannula to the rest of the body. Next slide, please. So this is just to touch very basically on this, just kind of the history of the LVADs. and what they look like then and now. So the earlier LVADs used pulsatile technology, meaning that they mimicked what was a physiologic pulse. So it's supposed to mimic what your heart rate or heartbeat is supposed to look like or feel like. And now we have gone through 3 generations. So there was the HeartMate XVE, HeartMate 2, and now the HeartMate 3 and the HVAD, which we no longer use. And the flow is now more continuous, meaning that it does not mimic a heartbeat anymore. And it's a regular continuously flowing pump. And now we have what's called a centrifugal pump, meaning that it flows perpendicular to the pump. And then next slide. And just to touch on this very, very briefly, just to show what this would look like. So you have normal physiology, which is where you have a systolic and a diastolic blood flow, which creates a pulse pressure. And the initial LVADs used to look like this pulse pressure, but now they look more like what happens at the capillary end, which is where you have a continuous flow. So it no longer mimics the pulse pressure or the pulsatile movement, but becomes a continuous flow LVAD. Next slide. So the latest one we have on the market that is the most used is the HeartMate 3. And it's really a remarkable device because it's completely levitated. It does not have any really bearings on any part of the pump. It's levitated through magnetic technology, and that makes for a very hemocompatible pump. And this prevents shear stress, and so this allows the blood to flow more smoothly. And the reason for this is because it reduces stasis and it minimizes thrombosis in the VAD, which is an issue with the first and the second models, where you would have a very large incidence of pump thrombosis. I just wanted to give a quick look at what the HeartMate 3, which is the most used and now the most latest generation of LVADs. And just to talk about what the trial was, so this was a landmark trial called the Momentum trial, the Momentum 3, which looked at the 2nd generation and the 3rd generation pumps. And what they found with these pumps was that there was if you go to the previous one. Thank you. And what they found was that the centrifugal pumps had a higher event-free survival, which was need for pump exchange, and a higher event-free survival from death, with secondary outcomes of an improvement in bleeding and stroke. So this is why we now use this almost exclusively over pulsatile pumps because they are more hemocompatible. Next slide, please. It also has a lower risk of suspected pump thrombosis, and that seems to be a signal to a less stroke, less bleeding in these pumps. And so really this was a landmark trial and a paradigm-shifting trial for us. Next slide. So I just want to show what the LVAD parameters look like. We measure the pump flow, the pump speed, the pump index, and the pump power. And these are parameters that we look at the HeartMate 3 and the HVAD. And what we're looking at basically is how much flow does the HeartMate give and at what speed. And the speed is adjustable, and that helps us change the flow. And we can also see by that how much power that the motor is giving us. And so really we're able to control how much flow the LVAD is able to give and how much support it's giving the patient. Next slide. And I won't touch too much on this, but really it's just for us to show that the flow is directly proportional to how much speed and the pressure across the gradient. And this really shows us what the HQ curves are and how we design these pumps to mimic continuous flow. Next slide, please. So as great as these pumps are, they are not without their complications. The ones that are listed on the left are really the most significant ones, with pump thrombosis, stroke, GI bleeding, driveline infection, and RV failure being the most prominent. And you can see on the right side that what you really get early on in the pump is what we call the hemocompatibility related adverse effects, like pump thrombosis, stroke, bleeding. But you could see that the HeartMate 3 is superior in that compared to the HeartMate 2. Later on, you'll see more of the late events, meaning the hemodynamic related events, such as right heart failure, aortic insufficiency, as you have different dynamic changes that come with the LVAD. So even though it is a great option, and we see a good deal of improvement with these pumps, they are not without their own side effects and their own complications. Next slide. So complications to an LVAD implant, there are some that we do look at that we would say a patient is not a candidate for this. One, if there's an active malignancy. Two, if they're advanced age, and every center is different on what they consider advanced age, but the general consensus is over 75 to 80 is considered a contraindication. Any severe comorbidities that would preclude a meaningful outcome, such as ESRD or dialysis, or severe liver disease, such as cirrhosis. Any active bleeding, inability to tolerate anticoagulation because these pumps require a blood thinner, namely warfarin, in order to run. Any anatomic barriers, such as restrictive and hypertrophic cardiomyopathy, and that's because these LVADs won't fit in a small LV. So you really need the patient to actually have some degree of dilation in order for there to be room. And any inability to care for an LVAD, whether if they don't have enough caretakers, unstable housing, active psychiatric illness that prevents them from being able to care for their VAD, etc. Next slide. So what are the outcomes after an LVAD implantation? So what we know is that long-term survival in successfully discharged VADs is actually pretty good, where if they have less than one predictive pre-implant predictor, such as renal dysfunction, or if they have prior strokes, we actually have a reduced mortality rate of 22% in 5 years. And that risk goes up with more and more risk factors, as the ones listed both, such as prior renal disease, other ventricular arrhythmias, strokes, etc. But overall, the outcome of these patients is very good, which makes it a very good advanced therapies option, either as a bridge to transplant or as a destination therapy. So we're going to switch gears a little bit just to talk a little bit about cardiac transplantation. So introduction to transplant, just to look at the numbers. So we know that there's over 8,000 patients at any time listed waiting for a transplant. And we know that at any point, with last year actually being the highest amount of transplants, about 4,500 patients ended up getting a transplant. And this is from the SRTR data, which is our national registry. So overall, there are a very large amount of patients waiting for a transplant. And so there's huge disparity in patients waiting for a transplant versus who actually gets one. So when we look at the indications for transplant, there's absolute and there's relative contraindications. So just to go through these, indications. So just to go through these indications. So you have your absolute indications, which are if they have severe hemodynamic compromise, dependence on inotropic support, recurrent ventricular arrhythmias, persistent NYHA class 4 symptoms, or end-stage congenital heart disease. And then you have relative contraindications such as unstable ischemia, not amenable to intervention, a peak VO2 less than 12, which we had indicated prior is in a sign of advanced heart failure, or a poor prognosis based on the survival scores that we use. And I just want to make a note here. If you notice, EF is not what we use for an indication for heart transplant. So a patient could have an EF of 50% per se, but if they have other signs or indications of advanced heart failure, that would still be an indication for transplant. So it's a common misconception that EF is one of the things that we use, though it is one indicator. It's not one of the ones that we use to define advanced heart failure or indications for transplant. So when we look at the contraindications for transplant, again, we have the absolute and the relative. Absolute are very similar to what we see for patients with an LVAD. Any irreversible renal disease where you can't also do a concurrent renal transplant. Irreversible liver disease, and many centers now will offer heart liver. So if they don't have an ability to get a liver transplant also. Irreversible parenchymal disease of the lungs. Irreversible pulmonary hypertension, because that precludes to severe RV failure, and any active malignancy. The relative contraindications are patients with prior debilitating stroke, frailty overall, or severe obesity, because we know these patients do worse because of increased rates of infection, active infection, advanced age, and that once again is very program dependent and what's an advanced age. Any psychological instability that they don't have care for. So having a prior psychiatric illness is not a contraindication. It's just that it's not treated. And any diabetes with end organ damage that's poorly controlled. Next slide. So I won't go into all of this, but I just wanted to show kind of how extensive the workup is for a cardiac transplant recipient. It requires a lot of hemodynamic testing, cardiopulmonary testing, an extensive workup, including an infectious workup background to make sure there's no preponderance for infection post-transplant. So just to kind of highlight how significant the evaluation for a cardiac transplant is and how extensive it can be. Next slide, please. So this is our allocation system. So it's based on criteria that's hemodynamically related. So we have 6 statuses, 1 through 6, and this actually was revised in 2018, where it used to be 2, status 1, 1A, 1B, 2, and now it's been further stratified to be 1 through 6. And really we use it the way we define how we rank a patient on this tiered system is by their hemodynamics and how sick they are, whether they're inpatient, outpatient, and whether they're requiring mechanical support such as ECMO in order to be on life support in order to be stabilized. Next slide, please. So just to touch basically on what we do for procurement. So the traditional pathway was donation after brain death, where a patient is declared brain death. The heart is procured, and this is the classic, put it in an ice box and bring it to the transplant center. But since then, we've had a new pathway, which is DCD, which is donation after circulatory death. And this refers to the recovery of organs from a patient who has died during irreversible loss of circulatory respiratory function, such as when the heart, my apologies. It's donation of circulatory death, which is an option when a patient has suffered a catastrophic neurologic injury but does not meet the medical criteria for brain death. So the first step would be to determine if the patient is not able to survive on life-sustaining support, and that the patient would, if they were to be withdrawn, they would not be able to survive on their own. And there's different ways to procure these hearts, and oftentimes it's an ex situ or ex situ machine, which keeps the heart pumping after it's procured. Next slide, please. So we look at the surgical techniques. There's 2 types, and if you click, both types will come up. So there's the biatrial, which is the less used, and the bicaval, which is the more commonly. And just to kind of save time, the bicaval method is when you connect the donor left atria to the donor left, the recipient left atrium, and it connects the 2 donor vena cava, which is the superior and inferior, and that preserves the native right atrial function. So this is overwhelmingly the technique that's used now, and the reason is because it preserves the right atrial function, and it also decreases the rate of arrhythmias post-transplant and has preserved sinus node function, which is important post-transplant. The downside is more complex and it takes longer to perform, but they have a better durability and better outcomes. So this is the predominant use of surgical technique that we use now. Next slide.
Preethi, I'm just going to jump in and say maybe we can try to wrap up in the next 2 to 3 minutes.
Sure, thank you. So we have an extensive use of immunosuppressive strategies that we use, which includes steroids and a whole slew of immunosuppression agents that we use. Next slide. And this really kind of highlights all the different pathways that we target in order to attain active, aggressive immunosuppression. Then if we go to the next slide, this is just an example of how frequently these patients get biopsied. because there's intense surveillance after these patients are transplanted to ensure that there's no rejection. And the next slide. And this is just kind of an overview of some of the things that we could see post-transplant, with the main complications being rejection, infection, cardiac allograft vasculopathy, which is basically narrowing of the coronary vessels of the transplanted heart, and malignancy. And if we look at the leading causes of death, what we see is that early on post-transplant, in the first 30 days, it's really graft failure or multi-organ failure that can happen from a surgical reason, et cetera, as really the main cause. With as you get out, the most common causes of death, such as 15 years out, is coronary allograft vasculopathy or malignancy, which is often something that we see after chronic immunosuppression. Next slide. And this is just kind of an overview of all of the different infectious risks that we have that we actually start prophylaxis on for these patients. So infection is a real risk post-transplant, and we do what we can in order to prophylax against these infections. So when we look at the overall survival, what we know is that the overall survival is about 80.3% at 5 years. And the 1 and 3 year patient survival is about 91.5 and 85.9% respectively. So overall, very good survival. And this is due to aggressive immunosuppression, appropriate infectious prophylaxis, and close monitoring of these patients. What we know is overall survival, the poorest outcomes are associated with increased frailty, congenital heart disease, advanced pulmonary disease, and if they go into this into transplant as a higher intermax classification. Next slide. So key points, advanced heart failure is associated with high mortality and morbidity, requiring early recognition and evaluation. Advanced therapies options for these patients include durable mechanical support or cardiac transplantation. And LVAD therapy and heart transplantation require rigorous evaluation, early intervention, and if this happens, they have good long-term outcomes. Next slide. Questions? And thank you for letting me speak today.
Thank you so much, Preethi. It's incredible the amount of evaluation and follow-up that's required for some of these patients. And so for primary care providers out there, I think just understanding and having a sense of the magnitude of how much care is required is helpful. Are there questions? I have a couple, but we have one from Anne. Go ahead.
Thank you so much. That was a really good presentation. I know you talked a little bit about, the kind of the 5-year mortality, but at this moment, like when you're counseling patients, what is the lifespan that you would say you would have for a transplanted heart at this time when you counsel patients?
Yeah, that's a great question. And actually, it was a slide I was hoping to squeeze in, but I was already at 39 and I was pushing my luck, so I wasn't able to add it. But so the last SRTR data actually quotes that the survival, we're seeing like up to 12 to 15 years. And then anecdotally, we're seeing even longer. It's not being captured in our registries, but what we're finding is that we're seeing survival out to 12 to 15 years, even approaching 16 with transplant. With LVAD, not quite as long, but we're seeing it approach even 10 years on an LVAD. So overall, pretty good long-term outcomes.
So with that, like, UW would be like where we would, refer patients for transplant. So what is your absolute cutoff of like referrals for heart transplant patients for age?
So for us, and it's kind of a moving target. We would say for a transplant, when they start to reach the age of 70, they are a little bit higher risk. But we do have patients that we consider, and some of the things that we look at is what their activity level is, how frail they are, and kind of overall how how robust they are, which is hard for an advanced heart failure patient. So we have patients that we've transplanted above 70, 71, 72, but 70 is where we kind of start to draw the line that it might be a higher risk. For LVAD, it's a little bit older. We tend to LVAD patients even up to 75.
Thank you.
Preethi, Sarah Rogers asks, how do people feel when they're on an LVAD? Are they back to their normal 20-year-old self?
Yeah, a lot of patients have found that after LVAD, they may not be able to get back to fully if they didn't have heart failure, but they do notice that they have a significant return of their functional abilities. So, a lot of these patients, by the time you LVAD them, they're not able to get out of bed, they're not able to walk to the door, but they're able to, get on with the normal activities of daily living, shop, get back to their hobbies, you know, kind of do the things that they need to as a daily, activities of daily living. So a lot of them do feel better. I do give people the caveat, there are lifestyle changes that unfortunately go with an LVAD. Due to the nature of the device, like they can't go swimming. For some people, that's a hard pill to swallow. But for some people, it's like I never was much of a swimmer anyway, so it doesn't change things too much for them. But there are small lifestyle changes that they have to make for that. But for most people, given that the improvement that they feel, they feel it's a worthy trade-off.
Can I also ask Preethi if you could just very briefly describe your process for evaluating someone for transplant, and in particular for this audience, how do you evaluate someone from Idaho, and is it different compared to someone from Western Washington, specifically at the University of Washington, and what sorts of things have to be in place for you to make a decision to transplant someone from Idaho?
Yeah, so I kind of use very much the slide that kind of highlights what are the advanced features. Are they having all of those NYHA class symptoms? Are they having hospitalizations, et cetera? Are we de-escalating meds? So whether they're here in Idaho, kind of what we use as our scale for identifying becomes the same. If they're in Washington or local and we decide we want to move towards an advanced therapies evaluation, we start the process with our team here, and they start whatever is involved, the financial clearance, the social work, and all of the imaging. If it's somebody that's more remote, we've had patients in, like you said, Idaho or Alaska. We work with a team there to start getting the imaging, the CPET maybe, whatever we may need to do. We start getting them locally. And then actually we notify our financial team here to get that done. If there is a patient that we feel is rapidly declining and needs a more expedited eval, what we have done is we've just had them transferred to University of Washington and complete the evaluation as an inpatient. So that way we don't lose time because some of these class 4, stage D, higher Intermax, they don't have much time in order to kind of go through all this in a stepwise process. So sometimes I just we bring them over and just do an expedited eval and often have the committee evaluation right away to see what that timing looks like. Do we list now or do we let them stay in Idaho for a little bit of time before we list them and just have very close follow-up? So a lot of it also involves communication with the primary team too.